having a webinar on the same platform. Yeah.
Okay, good. So what? Good.
It will be on yoga, the art of living and the art of being.
Okay, मजा आएगा, बढ़िया.
Yes.
Okay, good,
Yeah.
very good.
But that's a very good platform because this is being transmitted almost 70 countries all over the world.
Yes.
So it has a very wide audience, very wide audience.
Very wide audience, yes.
So Dr. Anil has also joined. Dr. Anil Jain.
Hello.
Hello, good morning, sir.
Morning.
Department of Urology, SMS. बहुत अच्छा लगा. All of you, both of you have joined. And, hello.
Muted. You are muted. Dr. Shivam, you are muted.
Thank you. The technical team, Prachi.
Yes, sir.
You start your YouTube live streaming so that within 2-3 minutes we will. Yeah.
Yes, sir. We are on.
And it is very good. और अभी तो काट के वो सुबह को एक आज तरबूज काटूं छोटा सा ना तो चलो मैंगो काटती हूँ
Prachi, we are ready.
Yes, sir. We are ready. I'll just give the countdown. So we'll start in 3, 2, 1. Start.
Welcome, all of you, to this again platform of Department of Urology, SMS Medical College, Jaipur. Today we will have a class on TURP. There's a transurethral of prostate.
क्लास हो रही है वो अटेंड कर रहा हूँ.
Prachi, please mute everybody.
Yes. On it.
So today we will have a class on step-by-step approach of transurethral resection of prostate. The presenter would be our second year resident, Dr. Mahesh. And today we have two special invitees with us. Dr. Diwakar Dalila, he needs no introduction. He is professor in the Department of Urology, KGMC, Lucknow. He was previously head of the department there. And he has a tremendous contribution in Indian urology. He has done a lot of innovations. He has authored many books. He has published many papers. He has done so many things, particularly also in the field of public awareness regarding various urological problems. And he has around more than 136 videos on YouTube regarding all these problems and regarding in urology. So welcome, Dr. Diwakar Dalila, to our platform. Thank you very much for coming. Then we have Dr. Anil Jain. Dr. Anil, you're most welcome to our platform. And as we all know, Dr. Anil Jain is again a very senior urologist. He was the president of the state chapter of Uttarakhand and Uttar Pradesh of Urological Society of India. He passed out from CMC Vellore in 90, and then he came to Kanpur and established a department of urology at Regency Hospital. He did his first renal transplant in Kanpur, a town which is an industrial town, and there he started renal transplant in 1997. So it was a great achievement. And then now he has his own hospital called Noble Super Speciality Hospital with more than 100 beds. So again, a great achievement. Dr. Anil Jain, you're most welcome to our platform. And then today's moderator is Dr. S.S. Yadav, who was our head of the department in urology at SMS Medical College. So he would moderate the session. And I will hand over to Dr. S.S. Yadav to request Dr. Mahesh for the presentation. Dr. Yadav, please.
Dr. Beniwal, please start your presentation.
Good morning, teachers and residents. I'm presenting a seminar on steps of the TURP. TURP is successful minimal invasive surgical procedure of BPH size of 30 to 80 ml, and it is a standard therapy for BPH with moderate to severe obstructive loops when other methods fail. Anatomy of prostate for surgical point of view. Prostate is thinnest and most narrow anteriorly at 12 o'clock position, and care should be taken when operating at this area to avoid perforating the prostate.
Skillful चीजें होते तो बाकी क्या होती है?
Especially if the portion of the prostate is resected early in the operation. Instrument required for TURP is resectoscope may be 27 French or 24 French, video camera with rotatable head and cutting loop with roller electrodes, Alex evacuator 22 French Tyvek catheter, lubricant and the sterile irrigation fluid. Resectoscope is a combination of cystoscope and electrosurgical instrument which enables.
Mukesh, I will interrupt you. I will request all the viewers, please mute yourself. We should not have any disturbance. We would not enjoy the talk and the further discussion if we have disturbance like this. So requesting again all the viewers to kindly mute yourself. Yes, Beniwal, go ahead.
Resectoscope is a combination of cystoscope and electrosurgical instrument which enables the resection of prostate with electrically activated wide loop. In 1975, Jos Iglesias reported a reliable external spring-loaded continuous flow resectoscope that is the most popular resectoscope working element style used today. And irrigation, the properties of the irrigating solution should be transparent, which allows visualization, isotonic, electrically non-conductive, and non-hemolytic, non-metabolized, non-toxic, and inexpensive, and easy to sterile. Sterile water is rarely used because when absorbed in the large quantity during the process, it causes hyponatremia, intravascular hemolysis, and hyperkalemia. Therefore, non-hemolyzing solution of sorbitol, mannitol, or glycines are used most commonly, and these relatively isotonic fluid protect against the hemolysis, but cannot prevent dilution or hyponatremia because their intravascular absorption increases fluid volume without adding any sodium. Next is patient's position on table. Patient's buttock should lie on the edge of the table, and the angle of patient's thigh with the table should not be more than 45 degrees, and legs are kept in parallel to the table. Resection technique. All resection, the aim of the all technique is same, to remove all the adenomatous tissue from the inner zone, leaving the compressed outer zone intact, called surgical capsule. Differs on these techniques are differs only in order to which the bulk of tissue is removed. And in the old method, there are 3 stages. The first is establishing the landmark and removing main bulk of tissue, and third is tidying up. To establish landmark, first we should do urethrocystoscopy and complete examine the urethra and identifying verumontanum external sphincter and get idea about prostatic lobe enlargement and bladder neck, and look for ureteric orifice and any bladder pathology. This diagram showing 3 components of sphincter mechanism: bladder neck, intramural external sphincter, and the levator ani. And this is a cystoscopic view of external sphincter. Make sure that you have seen the sphincter. Bring the resectoscope out beyond it and cut off the water flow, and to see it contracts like the anus in its characteristic way. In the small prostate, the verumontanum is well upstream of the sphincter, but in the large bulky prostate, the lateral lobe adenomas bulge down past the verumontanum and distort the sphincter. So more chances of injury of a sphincter in the large prostate. Next point is removing the main bulk of the tissue. Basic rules for resection technique: 3 basic rules: the cone excision, excavation of the capsule, and resection of the apical tissue. Reason for this triphasic procedure is phase 1 and to permit rapid tissue removal, since the danger of accidental injury is slight, and in the final stage 3 requires slow, careful surgery because it's lie close to verumontanum and external sphincter. Next is cutting the chips. Chips is carried out by a halo of a spark between the dithermy electrode and tissue. Cutting takes place without any contact. There are 2 methods of cutting: Naisbitt, Barnes, and Naisbitt method. In the Barnes method, it's a usual method of cutting the chip of the edge of seed, and in the Naisbitt, the cutting of the chip of before the loop enters the seed and prevent any possible damage to the telescope. Most of urologists use Barnes method, but there is more chances of damage of lens in the Barnes, so it is safe to bend the loop to allow it to enter the tip of the seed, as long there is a gap between loop and telescope. Establishing a rhythm when resecting the bulk of the lateral lobe. Once landmark have been established, the time is saved by making sure that every stroke remove maximum amount of tissue, and a rhythmic hand movements required for cutting a chips. The first of all, lift the resectoscope to allow the loop to sink in, then keep it level as you cut the chip, and finally depress the seed to cut off the chip. If the electrode does not spark cleanly, it will do not cut, but will coagulate or charge the tissue. There is a most likely to occur if you press the loop into the prostate instead of letting the spark to do work. A crust of carbonate tissue may cover the loop, then clean it and again start. If the loop does not cut at all, carry out the following checkpoints. First of all, make sure that loop is sitting firmly in the holder, and a click sound can be felt, heard or felt as loop fits into the holder. And check the loop is not broken, and next check that diathermy plate is securely attached to the thigh, and check diathermy lead is attached to the machine, and check that the wire within the diathermy lead has not worked loose at either end, and check irrigating fluid. A common mistake is for the theater team to hang a bag of saline instead of glycine. Still, if diathermy is not working, then change the diathermy machine. Median lobe. During the median lobe resection, very carefully in a systemic manner, as shown in diagram, from superficial to deep. While resecting deep portion of the median loop without current is used to gently lift the posterior flap of the median lobe tissue, which is lying on bladder surface. Now resection can be performed without any risk of the bladder injury. During the median lobe resection, perforation at the inferior bladder neck can easily occur if the line of resection is too straight or it is not curved to fit the shape of the prostate in this area. And resection of the bladder neck tissue, put a finger in the rectum for guidance, and the loop without current can be used to lift a flap of prostatic tissue prior to cutting. This helps avoid perforation and subtriangular tunneling. Sometimes resection of the enlarged medial lobe allows the lateral lobe to come closer, as shown in diagram. After resecting all medial lobe, make sure that Badenoch's arteries at the 5 and 7 o'clock have been controlled. And identifying bleeding at the bladder neck, fill the bladder usually help in the locating the bleeding vessels on the interior bladder neck, and sometimes limited resection of covering chip of tissue is necessary. And other method, insert a finger in the rectum or applying an external suprapubic pressure can assist in the locating and coagulating the bleeding vessels by altering the orientation of their flow and bringing the bleeding right into view. During the apical resection, we should carefully do not start this part of the resection until you have completely controlled the bleeding, and repeatedly check the position of the verumontanum and the sphincter, and take only very short chips. Insert one finger in the rectum to lift up the apical tissue to the resectoscope, and if bleeding is present near a verumontanum, coagulate very carefully. After emptying bladder, withdraw the seed beyond the sphincter, then gradually advance it and to see where you have to left adenomatous tissue. At the end, slow withdrawal of resectoscope helps demonstrate a flap of the tissue hanging down from the roof, and this should be carefully resected to avoid a ball wall effect. And during the hemostasis, no charring or burning, only cessation of the bleeding and little whitening of the tissue, and should not black it. Small arteries are coagulated by touching the loop at tip of the artery, but a large vessel may not be controlled by coagulating it and coagulating its mouth. The trick is to squeeze the wall together by applying a loop just to one side to seal them, and coagulating current is applied. This is a bounce bleeding. When a stormy jet blood rebounds of the opposite wall of the prostatic fossa, it's called bounce bleeding. So turn your attention to contralateral wall of the prostatic fossa to find out the true source of the bleeding. And sometimes the bleeding artery is shooting at straight at the telescope, which leads to uniform red blood. Trick is to advance the resectoscope beyond the bladder and angulate it to compress the vessels. Then slowly withdraw the seed until the opening of the artery and coagulate it. Prophylactic coagulation. Sometimes, if resection is likely to bloody, we should do prophylactic attempt to control the main artery before one start to resect. Using the rolly ball, coagulate the prostate at 7, 5, 7, and 10 o'clock, where Badenoch and flocked arteries are present in the enlarged gland. Venous bleeding is more difficult to detect than arterial bleeding. So slow down the inflow of the irrigating fluid to find out little veins, and it is worth taking time to go over the entire inner surface of the capsule at the end of the operation to seal them. If the copious oozing is still present, then use tamponade, and it compresses the neck of the bladder where the most of the offending vessels are situated. Still bleeding fails to stop, then reinsert the resectoscope and look for any bleeding artery just inside the bladder neck at roughly 12 o'clock position can easily be missed. So look here. Different techniques of the resection. Mormai technique. In this technique, the resection is started from medial lobe and followed by lateral lobe, ventral part, and in last apical lobe. And Flocks and Culp technique, the Flocks prefer to start with medial lobe, then segmented with the lateral lobe at the 3 and 9 o'clock position. And in the Nasby technique, generally we start with resection from ventral part between 11 and 1 o'clock, and followed by both lateral lobes are resected and medial lobe, and finally the apex lobe is resected as shown in diagram. And in the Milner's technique, deep incision directly into the lateral lobe at 3 or 9 o'clock position and proceed until the surgical capsule is reached, and further resection performed from this starting point. And the Richard Notley as shown in diagram is after removing the medial lobe, resection is started from 7 o'clock in clockwise manner and reach up to the start point again. Evacuation of the chips, and when one break the rhythm of the resection to remove the chips, the time is wasted to keep the number of evacuation to the minimum. For example, when the chips begin to fall back into the empty prostatic fossa and get it within of the loop. Alex vector is generally used for evacuation chips. It should be used gently. If it is used roughly, it's possible to rupture the bladder, particularly in old ladies with thin bladder who have undergone bladder tumor resection. And some surgeons prefer a wide nozzle hand syringe to Alex evacuator. This is known as Toomey syringe, and other one is modified. This bottle modified Alex evacuator. Intraoperative complications may be hypotension, TRP syndrome, hemorrhage, perforation of the bladder and prostatic capsule, hypothermia, and maybe complications of the positioning and erection. Now is a short video for demonstration of the TRP. Patient is draped in lithotomy position. This is a special TRP drape. Only genitalia of patients come out of the hole, and there is a small hole below the main hole, which is used digital examination. In the middle of the operation is required, and there is a funnel. So all irrigant fluid will drain out into the funnel. Next step is cystoscopy. The first step of the actual operation is doing a good urethral cystoscopy. Put a scope under vision, examine the urethra for any stricture or raw area in which somebody can have because of catheter, and then see the area of the sphincter. This is area sphincteric urethra, and now look for verumontanum. This is verumontanum. And then you should try to have an idea about the lobes of the prostate gland. These are both the prostatic gland, and inside you should look inside the bladder and first find out where are the ureteric orifice and an assessment of distance between the ureteric orifice and prostate, and look for any bladder pathology. Finally, get idea about the bladder capacity by palpating at the suprapubic area, because you should know how much fluid will get accumulated in the bladder without any problem. And next step is dilate the urethra and insert resectoscope. First, you have to dilate the urethra by Eccleston bougie. You can pass like this and then rotate, or can directly pass like this, and you have to let it go by its own weight. You don't have to push it, and it reaches to sphincter urethra. Dip it gently. This will go in the bladder and rotate clockwise and anti-clockwise, and it's sure we are in the bladder. Withdraw in the same direction, and when withdraw, always examine the tip for presence of any blood. If no blood, then no harm. But now, before introducing seeds, put some jelly in the urethral lumen and introduce seed with trocar. Hold the penis vertically upright toward the ceiling of the theater, and seed is vertically in. If leave it in, it automatically slip down with gentle force. A gentle force is applied, and after reaching the sphincter, gently dip with slight small jacks, and now you will give a feeling on entering the bladder. It is freely moved, then remove obturator, and irrigation fluid is coming out. It is a proof that we are in the bladder. Next, check land point and assess the prostate and stabilize the resectoscope. Now introducing resectoscope, which is loaded with bipolar loop. When introducing it, ensure that the water inflow is on, and if it does not do this, the seed is dry and certain amount of air get captured within seed. So insert with the irrigation and then lock it. Now it's lock and loop in place. At all part of the resection, dot over the camera head should be face 12 o'clock position to maintain orientation. If you rotate the resectoscope, camera should face at 12 o'clock position, so vision and orientation will be maintained. When connecting the water channel inflow, look at arrow at channel, and fluid should drain out through the outflow channel. Before start, always see for verumontanum and sphincter. This is verumontanum. A button shape structure in some patient is a vertical mountain, and look for external. This is external sphincter. Sphincter is U-shape, and look for the distal limit of resection on both sides. Now fix the instrument sheath. Sheath is held in the left hand and should be stable on the penis. Even after removal of the right hand, it should not move. This prevents injury to external sphincter. If not fixed by mistake, you can come down beyond the verumontanum and may lead to incontinence. And next step is resect right lobe of the prostate adenoma. This is 6 o'clock position. Rotate this is verumontanum and rotate camera. Then made a anterolateral cut at 12 o'clock position. and put it back into bladder. Chip and 2 or 3 more chips are removed at the same place, making anterolateral groove. The cut is again put in back in the bladder, still deepening the groove up to the bladder neck or capsule. This is called Nesbitt technique of resection. If any bleed is present, then coagulated. Now, details the lobe of prostate from right side by cutting few more chips and let it fall in the floor. Now, and resect this lobe from lateral to medial, and all chips put it back into bladder. So first do clear right lateral lobe. And next is resect the left lobe and then posterior part. Rotate the camera towards the left lobe and start resection with the same groove technique at 1 o'clock. Usually 2 or 3 chips have to cut to reach the capsule, and resect the anterolateral part first. Again, push the lateral lobe towards the floor of the prostate and cut lateral to medially. And do complete clearance of the left lobe, then from lateral to medial. These are neck fiber, and yellow looking tissue is adenoma. So only remove adenoma, not remove much fiber of neck. If you over resect the muscle fiber of neck, may lead to bladder neck contracture in some patients. Next is apical resection and peripheral resection. While doing resection of the apex, cut only very small chips on either side of the verumentinum from medial to lateral. This is veru, and remove chip in the either side. And coagulate, if bleeding is present in this area, coagulate in this area should be white, and do not char or prostatic fossa. As in this patient, gland is very small, so less tissue anteriorly. So no need to resect completely in the anterior portion. So intensely leave 1 centimeter wide mucosal strip at 12 o'clock in small prostate. And next step is to remove prostatic chips. Sometimes chips accumulate in the prostatic fossa. One is to push back into bladder, or other method to remove the chips, let the bladder full, and then stop it flow of the irrigation. Keep the seed at the level of the verumentum, then remove the cutting. Some chips will come out which was present in the prostatic fossa. Again, insert loop and look for any bleeding and for smoothing of the fossa. After complete resection, Alex vector is used to remove chips from the bladder. While using the Alex evacuator, it should be airtight and bladder should not be over full. Push gently and move the tip to the left and keep it tip in center, and again move to the right and repeat it. In the Alex evacuator, as the fluid is clear, hence no bleeding is present. And again, after evacuation of chips, relook for any bleeding and chips inside the bladder. And next step is placing the triple lumen catheter. This is a triple lumen catheter. This can put directly, or but in some patient, if we think deep dissection is done at the bladder neck, it may stuck at the bladder neck. So use introducer. Catheter is fixed over introducer, and use some jelly and jelly as a lubricant, and catheter should tightly fix over introducer and pass like a dilator into urethra. And after insertion, first inflate the bulb of Foley's with saline. Saline may be used according to size of prostate, in 40 or 50 ml. And then after inflation, remove introducer again in the same curvature maneuver. So, and at the end of the operation, never forget to reposition of the prepuce forward. Thank you.
Thank you, Mukesh. You can stop sharing. And before the moderator, Dr. S.S. Yadav, puts, maybe we put the house open for the question answer session. We would request our invitees, Dr. Dalila and Dr. Anil Jain, for their comments. And Dr. Dalila, we are really thankful to you for having allowed us your own video on YouTube. Thank you very much. And I think you have also a small video clip that you would like to show us. So I think you can go ahead, please.
Good morning, everybody. And thank you, Dr. Shivam, for asking me to be here. And there's no, you don't have to be thankful to me. In fact, you have made my day. Because it's a pleasure to see your work being utilized. And there cannot be a better platform than SMS Urology to use whatever I have put on my YouTube. And thank you, Mukesh, for making a very nice presentation. You have actually used very nice diagrams to explain the technical part of transurethral resection. Very nice. I also learned a lot from your presentation in this morning. The point I'm trying to touch upon is resection of the median lobe. Because this is which I could not cover in my tutorials on transurethral resection. And so I thought if I can show you my screen. Can you see my screen? Okay.
Now we can see. Yeah.
You can see my screen?
Yes, yes.
So the point I'm trying to bring forth is resection of the middle lobe. Now mind you, these are two words that are used, middle lobe or median lobe. Both have same thing, but some people favor middle lobe because they say right lobe, left lobe and middle lobe. Some people say median lobe, so the same thing. So this is sometimes a challenge in transurethral resection, and how should you decide? Mukesh has shown one technique where he showed 1, 2, 3, 4, 5 chips straight, and then trying to dip the beak into the bladder and lift the median lobe and cut it. This is standard way of cutting it, but this may not be applicable in all situations. Why is the resection of median lobe is a troublesome thing? First of all, because of a large lobe which is jutting at the level of bladder neck, you are not able to see behind the middle lobe. And because you are not able to see behind the middle lobe and you put your loop inside the bladder and cut the median lobe, so when the loop is going inside the bladder, at that point of time you can make injury to trigone or sometimes even to ureteric orifices. And second point is that the raw surface of median lobe is facing the bladder. The bleeders are directed towards the dome of the bladder, not towards you. So they can bleed and you may not see them completely, and this results in greater blood loss in the operation. So these are two technical issues with the median lobe. That's why it has been sometimes a real challenge to handle it. What I'm trying to tell you is that when you perform a transurethral resection, you should study the morphology of the prostate very well. I'm sure some of you have seen my video on YouTube where I've discussed about the variations in the shape of the prostate gland and how does it apply to the performance of transurethral resection. The prostate gland can be shaped like pumpkin, can be shaped like papaya, right? There are various can be shaped like a potato. So various variations of shapes are possible, and you will have to modify your technique. All of you as a resident know about size, 40 cc, 60 cc, 80 cc, and how should it influence the technique. But I have been emphasizing equally on the shape. But here I want to tell you about the middle lobe anatomy, which you must understand well before you start resecting a middle lobe. There are certain variations in the middle lobe anatomy. One, and you have to see this in 3 dimensions. First, you see how much vertically it is jutting inside the bladder lumen. This may be like this, or this may be even like this. So you can have this way the median lobe can grow into the bladder, vertical growth. The second is anterior posterior growth. Anterior posterior means the patient is lying supine in front of you. It can grow into the bladder neck area, or it can go backwards into the prostate like this, backwards into the bladder like this. So this is an anterior posterior extension of the median lobe, right? And then you can have horizontal growth. The median lobe can be attached to bladder neck for about, let's say 3 centimeter here, or even 1 centimeter in another patient. So this is the lateral way, or horizontally the median lobe can be a broad based median lobe, a median lobe can be a narrow based median lobe. So the point I'm trying to make is you have to study X, Y, Z dimensions of the median lobe before you go and start resecting. Also, you should see one more factor, that this is the lateral view. You should see median lobe is of course there, but how much is the posterior lobe of the prostate? Here in this diagram, it is shown here as a thin prostate lobe. But you look at this is bulging more, and this is bulging more. Now this has implications in transurethral resection of the median lobe in the technique that I'm going to tell you. That how much is the bulk in the posterior lobe and how much is the bulk in the median lobe. Usually those patients who have large median lobe also have a significant amount of posterior lobe growth. Now then, having known this concept of anatomy of middle lobe, how can we preoperatively find this out? Endoscopy alone is not a good way to know it. So apart from knowing size, shape and middle lobe anatomy, I recommend to you that in all patients of prostate gland beyond 60 cc or 70 cc or 80 cc, use a CT scan or MRI with catheter in situ. Now this is not in the guidelines, but this is what I've been practicing over the years and I've been benefited terribly, and I'll show here some variations of the anatomy of the prostate. Why I am saying a reference to catheter and urethra? Because when you do transurethral resection, you are operating through the urethra, right? And you want to know that in reference to my resectoscope sheath, how much is the prostate on right side, how much is the prostate on the left side, how much is the prostate anterior, how much is the prostate posterior, and then of course the middle lobe. So the reference point of view should be the urethra, and here I want to simulate on CT. Typically, you know the prostate as right lobe, left lobe like this. Right lobe, left lobe like this. And that's the kind of picture you will get on an MRI or CT in a coronal section. Right lobe, left lobe, they're usually similar, right? And that's the kind of picture you will get in sagittal section. You will see a catheter, and I hope you can see here okay, just 1 second. Okay. You can see here my cursor. This is the anterior part of the prostate, and this is the posterior part of the prostate, which you have to resect. And you are working through the center, right? Now I want you to look at the variation in the anatomy on the CT. Now look at this CT, this MRI picture. This is the prostate so big anteriorly and so big posteriorly, looks similar, right? But look at this picture. This is the bladder, the catheter. Anterior to catheter is hardly any tissue. and whatever you have is posterior to the catheter. Look at this here. Posteriorly you have less tissue, anteriorly you have more tissue, and as you come down towards the apex, you have more adenoma. So the adenoma here is so much. If you leave all this anterior adenoma in resection, the patient will not void later on. Most people concentrate on clearing the floor of the prostate and the lateral of the prostate. And if you don't clear in this patient, the anterior place, you will be in trouble. Look at this patient. Hardly anything in the posterior part. It's all anterior. It's all anterior. This is the patient had an abscess formation here. All anterior prostate. So these variations are possible provided you know about them on CT. So the point I'm trying to make is, if you utilize this kind of CT MRI imaging and take picture in 3 section, sagittal, coronal, axial with catheter and urethra, you will know about the median lobe. Look at this median lobe here. This is the median lobe which is protruding into the bladder, and look at another picture. This is also median lobe which is looking like bladder tumor. This has gone so much posteriorwards into the bladder. I was telling you the median lobe can grow into the bladder neck, or it can grow inside the bladder. So here it has grown inside the bladder. In this patient, this is also median lobe. Look at this median lobe, whole this is a median lobe. The bladder is full, bladder is empty here, of course, because of catheter. That's why you are thinking it is too big a median lobe. If the bladder is full, such a picture will not come. But in any case, it is not a small median lobe by any chance. And this is the catheter. The black dot is the catheter. Another picture. This catheter is sitting over the median lobe, and this all is a big median lobe. This white is the contrastant bladder. This is the median lobe. The contrast goes on all sides of median lobe. Another median lobe attached from one side, protruding like cauliflower into the bladder. So point I'm trying to make is that median lobes are in 2 patients, you will never find a similar median lobe. More you learn transurethral dissection, you start appreciating that there are huge variations in the anatomy of median lobe, and unless you go systematically studying them in concept and studying them on CT, you will not know. Now the technique that I want to tell you is the which one I follow. Now let me tell you 2 things here. First of all, this is the technique for a medium sized median lobe, not too big. And then you should have, it is for a medium sized median lobe, and you should have some tissue in the posterior lobe also, right? There are 2 requisites for this technique that I am telling you, and this is the lateral view of my indication. First thing is, and this is the coronal view, first thing is you create deep grooves at 7 o'clock and 5 o'clock. You create 2 grooves. Now by creating these grooves, the advantage is your irrigation fluid will flow through these grooves into the bladder. Your vision will remain clear. If you don't have these grooves and you start cutting median lobe, then the irrigation fluid does not flow so well from prostatic urethra into bladder. So your bleeding is not, your vision is not very clear. So if you create these 2 grooves, your vision becomes clear. Secondly, the median lobe of the prostate is free from the lateral sides. It becomes like a snake hood. It can move towards you, it can move into the bladder once you cut from the lateral sides. So it's more free. And third is, you can go into this groove, your sheath can go into the groove, and you can go into the bladder if you have to inspect inside the bladder, and you can come back. So this groove provides you all these facilities. And then what I'm saying is, now you resect the prostate, not the median lobe first. Resect the prostate, the posterior lobe of the prostate above the varu, and you create a crater here. And this crater should be, I think, should be 1 loop, 2 loop, 3 loop deep. And you should keep in the mind the size of the median lobe, and you have to create a crater something similar to the median lobe size. You can resect some bit of lateral lobes also to create the defect in the prostatic urethra. Now once you create that defect in prostatic urethra, what will next happen is the median lobe will descend into the prostatic fossa. Because now you have created a space below. So the median lobe which was lying inside the bladder and you would have difficulty in resecting it inside the bladder. Now it descends and falls in the prostatic urethra. This is the key point that I want to make. And once it comes in this way, you have to just resect it simply. See, now it is facing you. Resectoscope is the lens is able to look at the median lobe properly. You resect it as you resect rest of the prostate. So that is what is my point, and I thank you very much for giving me this opportunity to share this small technical point. And I stop my share and I have questions.
Thank you, Dr. Dalila. It was amazing. I have seen for the first time so many shapes of the median lobe. You have a wonderful collection. You can make a treatise on median lobe of the prostate. That was wonderful. That was really wonderful. Dr. Anil Jain, for your comments, and then we would ask our moderator to start the session for question answer. Yes.
Thank you, Dr. Shivam. And this opportunity, thank you for giving this opportunity to interact with PGs and with all of you. I hope I am, can you hear me? Okay. Dr. Dalila has always been a very, very good teacher and a very good pictorial presentation in all his presentations. There is no doubt about that. We all try to do the same things, but he puts it in pictures in such a nice way that it is so explainable even to a novice that everybody can understand. You will all agree with me. Now, what I want to say is I just want to summarize a few things. And this summary is that TURP should not be considered a minor procedure. It's a very unfortunate thing that the residents who are getting training and then going into practice, they think that TURP to kuch bhi nahi hai, chalo TURP to hai, chalo kar denge. You have to have a very good concept of each and everything what Dr. Dalila has said. I would say that before going for TURP, you have to have first patient factors, which you do in your OPD, that what age of the patient is this, what comorbidities are there, and what is the size of prostate, so that you can plan it well. Unless you plan it well, if you think that अरे prostate TURP तो करना है, चलो हम 15 मिनट में या 45 मिनट में करके चले आएंगे. No, you have to plan. You have to plan your time. You have to plan your facilities. If the prostate is big, you might have to take 2 hours, 2.5 hours, 3 hours. So there should be no hurry. There should be no pending procedures lying in that you have to do this after this, this after this. So very important is planning. Now, knowledge of anatomy of prostate. Unfortunately, since it is a benign condition, what we do in malignant condition that we try to find out the anatomy of the malignant tissue plus the adjacent areas. The same thing should be done in BPH also. So I would definitely agree with Dr. Dalila that we should include a CT or a MRI in the evaluation of the prostate, particularly when the prostate is bigger than 60, 70 or 80 grams. And to the residents, I would say that if they include it in their initial career also, this will be very good. It is a learning phase. Once you become experienced, you may not do it for a small prostate, but for larger prostate, it should be essential. I am also doing it, and that is why my planning is very, very nice while doing prostate. Second, I am just summarizing what you have already said. Landmarks is very, very important. We must know superior landmark, the bladder neck and the ureteric orifices, the inferior landmark, the sphincter and the verimontanum, and the lateral landmark is the false capsule on all the sides. So that recognition of the false tissue from the adenomatous tissue, that is very, very important. Unless you start recognizing, your eyes trained on the recognition of the tissue, that is the best anatomical landmark. So you not keep on digging in one area. Once you keep on digging in one area, then you are in problem. So this is what one should do, a preoperative planning. And while doing the endoscopy, do that, develop a habit of doing a bimanual examination almost in all cases. Bimanual examination gives you not similar information, but very much information what CT or MRI gives you. I say that even in outpatient, if you are doing a rectal examination, note down in your notes what is the transverse extent of the prostate, what is the vertical extent of the prostate, and how much bulk you can feel. The only problem with bimanual examination and rectal examination is that you cannot assess the anterior part of the prostate, which is anterior to urethra. That is one drawback of that, but it gives you a lot of information. So if you don't have a CT or MRI, you must develop a habit of doing bimanual examination in the OT itself with the resectoscope in place. Preoperative planning, I have already said that you must patient factors, prostate factors, and your time planning and your facility planning in the OT. Another thing while resecting the prostate, as Dr. Dalila has said, that median lobe needs a special attention. If you have dealt with median lobe, or if you don't have a median lobe at that time, I follow a practice of defining the capsule first. So what I do is I use a BNI blade, the Collins knife, and I put incisions at somewhere between 4 and 5 and somewhere between 7 and 8. And I go on going into the depth till I find the transverse fibers. So this makes divide the prostatic adenoma into three tridents. And later on, you can do in quadrants also if you do it at 2 o'clock position and 4 o'clock position, 2 o'clock position and 4 o'clock position. So 4 quadrants of the prostate or 3 tridents of the prostate I define in the initial phase. This is usually not possible in a very bulky prostate, but majority of the prostate, it is possible. So I avoid digging into the prostate and causing perforation and going into the venous sinuses. So if we keep, purpose is that we do not go beyond the false capsule. We are going beyond the false capsule means you are landing yourself in trouble. Hemostasis, one thing very important, because a good vision is essential for TURP. So you must do instant hemostasis. The moment bleeding is there, you must do it. Then assess. If the lot of tissue is there at that particular point, then you again reach to the false capsule and do a hemostasis there. So this is something like necessary instant hemostasis. Then if your vision is not very good, then you must do in between hemostasis, take out the loop, put roller electrode and do in between hemostasis even when the prostate has not been resected completely, so that your vision becomes much better. This will not take more than 3 minutes or 2 minutes. You can again change the roller to the loop and again start resecting the tissue. And the final phase is the final hemostasis. So final hemostasis you do, and at the level of false capsule, if you coagulate all the arteries, then the vision will be very, very clear and the post-operative effluent will be very, very clear. So these are the things which is very, very important. Today's generation is very good after this camera system has come. When we have learned TURP, there was no camera system. And we have learned the TURP by the movements of the operator, the actions of the operator, what he is doing. He must be doing now right, you must be doing now left. So that was the situation before the camera system came somewhere in 93, 94 or 95. And many institutes had acquired this camera system even after 2000. I remember doing my initial TURPs that when I used to do resection at the in anterior part, I used to sit on the floor with a patra and do resection in the anterior part, because otherwise the neck used to be like this. So those difficulties are now over, and this generation is very, very fortunate that they can learn with a good camera system, because good vision is the must for any surgery. Another point is lubrication. Good lubrication is avoids stricture complications in the postoperative phase. So in the initial phase, when you have done a preliminary endoscopy, after that, in between lubrication is also required. When you are doing, before putting the resectoscope, you must put good amount of jelly. Then in between lubrication, whenever you are doing a evacuation by the chips, ask your assistant to do a good lubrication at the meatus level, retracting the penis backwards, do a good lubrication, put on the resectoscope and then bringing the penis again. So this I follow, and this avoids particularly the submeatal strictures. So, and in the last, before putting the 3-way Foley catheter, you must put 20 ml of jelly and then put the catheter. This makes life very easy, and not only for the operator, but for the patient in the post-operative phase to minimize complication, particularly of submetal stricture and a bulbomembranous stricture. Next thing is that while doing cystoscopy, you must find out whether this urethra is adequate or it is narrow. So the points of narrowing are either at the submetal area or in the bulbomembranous area usually, or the bulbar area. So these are the patients where you must use a Otis urethrotomy before putting resectoscope. And then a point about hemostasis, that the final hemostasis should be done, in my view, not just by ball electrode, but by a roller electrode. A roller electrode gives you much wider area of hemostasis, good hemostasis. It does not do a pinpoint hemostasis. It does a wider area hemostasis. And only the mouth of the artery should not be coagulated, because then the chance of secondary hemorrhage are much more. You must coagulate the artery for a distance. Say about 5 millimeter of the whole artery should be coagulated. Otherwise, reactionary hemorrhage, arterial reactionary hemorrhage, you have a bigger chance. So these are the points which I want to say. Another point, somebody has asked the question about how to preserve ejaculation. This is my favorite topic, and I have done a lot of cases of an ejaculation preservation. I do it in younger patients where TURP is required, and I also do it in primary bladder neck obstruction patients who are quite young, even 30, 35, and 40 years of age. So what I do is that I preserve the ejaculatory apparatus about 1 centimeter area around the verumentinum. I don't resect. So I put a BNI electrode, I define my depth, I define my inferior limit that I will not come near veru. And then I resect the rest of the electrode. And I have found in many patients that ejaculation is well preserved. So thank you very much. This is what I wanted to say.
Thank you, Dr. Anil. Thanks a lot. Those were very important tips for all of us, not only for the residents. So wonderful. Thank you very much. I remember when you were telling about the video thing, we didn't have the video, I think about only 5 or 10 years back only we started having video. Before that, we had this only with the eye contact only. So I remember Dr. Sadasuki, how he used to teach us. Dr. Sadasuki, while doing the TURP, he will ask us to look into the telescope, and he is doing by his hand. So he was so confident of doing a TURP that without even looking, he will ask us to look, and then he will take a chip. So that's how we learned TURP, but it is so easy now for the residents. So the residents, I would request, take this opportunity, and because TURP is one of the most important surgery in urology, you have any query, just take this opportunity to clear out your doubts. So I would request our moderator, Dr. S.S. Yadav, to have his comments and then start the session for question answer. If Dr. Yadav is not there, then I would start there. There are some few questions in the chat box. Let's start with the pre-op preparation. So in the pre-op preparation, what are we doing? So to the invitees, do we start all prophylactic antibiotics in every patient? And how do you prepare this patient for TURP? Dr. Dalela and Dr. Anil, yes.
See, as you realize, the indications of robotic transurethral resection in our country, most patients come on catheter, and that is when we do transurethral resection. In West, the situation is different. There, the indication for transurethral resection is failure to have response to medical therapy. So our patients are already on catheter. Our patients have already tried all kind of therapies, allopathic, homeopathic, Ayurvedic, and then they come for resection. Resection is their last choice. Now, in that process of having catheter in situ, they mostly have associated low urinary tract infection in them. And this issue becomes more serious because they have multiple medical comorbidities also. Our elderly age group population, I think, is as sicker as in West. In West, you'll find a lot of healthy elderly males. In our country, beyond 60, 70 years, rural population, I'm talking, they're not in a very good shape health-wise. So they are nutritionally down, they are physically down, they have low urinary infection, they may have diabetes, hypertension. Some of them may be on anticoagulants or ecosprin because of heart disease. Or in our country, physicians start ecosprin left and right. If the hypertension, start ecosprin, and the patient will not know that I'm taking ecosprin. So you have to, in my preoperative preparation, you have to assess the patient first of all, and Dr. Anil Jain has alluded to these points very nicely, what all to see in the patient. Then in the urinary tract, is there a renal failure associated or is there an infection associated? Then I spend a lot of time in looking at my prostatic anatomy by DRE or TRUS or CT, whatever, right? So, and then ecosprin issue. It is now said that if somebody is taking low dose of ecosprin, you need not stop it. You can do transurethral resection with ecosprin on. And I have done it by mistake, forgotten to find it out, or patient did not tell us, and we went ahead, complete procedure was done. You can do, but I think if you know beforehand, and if you can stop safely, I would feel it is better to stop. I don't want to go into the literature discussions on to stop or not to stop, advantage, disadvantage, but to keep your field clear, to have a good postoperative recovery in the patient, better to stop ecosprin therapy 5 days before. Then I pay a lot of attention to the constipation factor in the patient. If these patients are constipated, the rectum is heavily loaded, and you are not aware of this, and you take the patient for OT, transurethral resection, postoperatively, they will strain to defecate, the hematuria will increase, and also secondarily what I observed, those patients who are constipated, they have higher incidence of infection, postoperative UTIs. Probably because the fecal matter has more concentration of E. coli in them, in that, and there's a translymphatic seedling from rectum to the prostatic fossa. So you have perpetual prostatitis, perpetual dysuria after the operation. So I start laxatives properly. I tell the patient, tell the attendant, be careful about the bowel function. If there's a problem, let me know. And I usually like to give enema a night before. So I'm little, you may call, little obsessed is the right word for constipation clearance prior to my transurethral resection. And I also give a free hand to my anesthetist to evaluate everything until and unless my anesthetist says go ahead, I don't operate any patient, because we have to give a lot of respect to anesthetists. They know lots of medical issues and they are the best person to decide whether the patient is fit or not fit. If patient is unfit, from an anesthetic point of view, I will not do anything. So that's all preoperative thought I must share. Dr. Anil Jain, may I add, please?
Yes. Dr. Anil, please.
Yes. Yes, Dr. Dalila, what you have said is right, and I am also very particular about the constipation part, both preoperatively and postoperatively. In fact, I say a sentence almost wherever I find a opportunity, that if you have a good neighbor, your life is very comfortable. So if the bowel habits are good in a particular patient, the urinary habits also become good. So this is what I take is, and therefore I almost give laxative in the post-operative phase for about 2 to 3 weeks to almost all patients, unless they start developing loose motions. So this is my practice. Second thing is, and I also give laxative, which is a combination of 2-3 things, not just a lactulose type of things or just a isabgol type of thing. I give a combination of what is, there is something having a lactulose and then glycerin and all this. So there is a good combination of this 3 mechanisms of treating constipation, and they are all 3 in this. So that is what I do. Preoperative enema, almost to all, may not be to some people. Then the thing is that inside the operation theater, you must be very, very vigilant. What is happening to your patient, to his vitals, and you might have to be in coordination with your anesthetist. You might have to instruct, because some anesthetists are hesitant in starting a transfusion. So I tell them that you start transfusion inside the operation theater. Don't allow the hemostasis to come down, the homeostasis to vitals to be disturbed before you start the transfusion in the post-operative phase. There is no point. If you are losing blood there, if you must start transfusion then and there inside the OT. And don't allow the vitals to come down or the hypotension to develop or the tachycardia to develop before taking action. I also feel that urine is a potentially contaminated or potentially infected fluid. So if you are not starting the antibiotics 1 or 2 days prior to, which is not a practice, I start before starting the resection or before starting my procedure. I always give a good gram-negative coverage antibiotic to almost all patients, continue that injectable antibiotic for at least 5 days, and then switch over to oral antibiotics for about 2 weeks, so that the fossa heals well within the range that it doesn't get a secondary infection. So this is what my practice is.
Thank you, Dr. Anil. All three of us are so equal at the wavelengths. My residents will know how particular I am about the bowel habits. I don't, in OPD also, not a single patient goes without a history of bowel habits. So I'm so particular, and definitely in prostate surgery, they know exactly. I insist so much on that they should not have any constipation, and even if before catheter removal, they should pass the bowel first and then the catheter be removed. Otherwise, there would be a problem. So thank you very much for stressing this point of bowel habit. And secondly, for the anesthetist, I have so many reasons to respect the anesthetist. So I don't have to speak. So the next thing is about when you put the, yes, Dr.
I just want to make a light comment for anesthetists. And this is with respect to all my anesthetists, and this is not by me, this is by Dr. Bailey in his transcatheter section book on TURP. He wrote that there is no point in hiring a dog and barking yourself. So if you have a very good anesthetist, don't bark yourself. Let him decide everything for the patient. So this is with respect to anesthetists. This is Dr. Bailey's sentence in their book. So for residents, it is an amusing statement, but this is so true in clinical practice. About the blood transfusion, Dr. Jain, I just have to share one thought with you, because I have had 3 young anesthetists, one after the other, in few years with me. They had been telling me that if you transfuse the blood pre-operative or post-operative just for very, your impressions rather than objective evidence of the need of transfusion, it has an immunity lowering effect. The dose of antigen that you give, the leukocyte, the lymphocyte, the RBC, everything, it lowers the immunity of the patient for a while, and they can have a greater degree of infection afterwards. So he said, if you want me to maintain good circulatory status and hemodynamic status, leave it to me. I will decide whether I give crystalloid, colloid, saline, what, but I will not the blood pressure fall in your patient. Don't worry. And I'll not have hemodynamic disturbances. It's my job to see whether I need blood transfusion in this patient, or you operate. You do your job, let me do my job. And he has cut down the blood transfusion rate in my operation in last 3-4 years to zero, irrespective size of the prostate. If prostate gland is bigger than 60 gram, he would give me hypotensive anesthesia, right? And hypotensive anesthesia, he's keep BP around 86 all the time, and I operate as if I'm operating on a boiled potato. And blood loss is so minimum. And then when I come towards the end of the procedure, he will build up the blood pressure to 120, 130 is the normal. If there's oozing, and then I know where are the bleeders and I can coagulate. So it saves my time, it saves blood loss from the patient, and it saves the need to give blood transfusion. So two things they have changed in my practice.
Yes, yes, Dr. Pilla, very nice. Yeah, definitely there is a difference in the anesthetists who are new and who are coming. They have changed the practice lot. And I am also finding it that the older anesthetist never used to be. The purpose is that your anesthetist should be vigilant in the operation theater. He should not be sitting and playing on the mobile, or that's what is most important. He should be vigilant, and he should be also looking at how much blood is being lost. So if he is coming on the foot side, if he is coming on the perineal side and seeing how much blood is being lost. So that is what I mean to say, is that you are the best assessor of how much blood has been lost. The surgeon is the best assessor of that. So what I meant, that you should be proactive when to transfuse blood. It does not mean that you transfuse blood to each and everyone inside the operation theater. You should be proactive. You should not delay the transfusion. That is what I meant. And the theoretical aspects which you are saying is definitely, they play a role. Thank you.
Right, Dr. Anil. And the last, because my wife, Dr. Varsha, because we are all both together in the OT almost. And so we all never forget after the surgery to thank her and her team.
Yes.
So this is a must for all anesthetists. You should thank the anesthetist after the surgery. So that is one of the tips that I would give to my residents also. So going ahead, yes.
For you, it is doubly important.
Yeah, yeah, because I have to go home also, right?
Apologies. That's why I said in the beginning, apologies to our anesthetists.
Yeah.
See, in fact, I must share you that my anesthetist is standing by my side when I'm operating transcatheter resection.
Yeah, that's what
he doesn't stand on the head end of the patient.
Yes.
Well, I have given once anesthesia, it's all done. Monitor I can see from this end. And I am seeing your camera, what are you doing?
Yes.
And now there have been occasions when he is telling me, sir, abhi resection kuch kam hua hai, lagta hai thoda. There is time, you can do it.
Yes.
There is a lot of, I can see some tissue.
Yeah.
Why are you worried? Go ahead. And he is telling me all the time to go ahead.
Yes, a good anesthetist is a very good.
Exactly.
Very good guy. Very good guy.
Exactly. I remember Dr. Varsha saying her teammates that just see what the surgeon is doing always.
So actually, I must tell you that there are the three minds now we are operating against camera. Me, my first assistant, my anesthetist.
Yeah.
Everybody is looking at the camera and telling what is to be done, what is not to be done.
Very right. That
so patient has three surgeons operating on him.
Yes,
Exactly. And if you want to know who is the best surgeon, then ask your anesthetist.
Yes.
Exactly. Who is the best surgeon in your department? Definitely. Right. So we go ahead with now we have the patient on the table. Positioning, I think, is a very important because many a times we don't put stress on how much the thighs are flexed. If the thighs are too much flexed, then it's not only a problem during operation, but also the patient may have a lot of problems post-operatively, backache and everything. So it should not be more than 45 degrees. And about the buttocks, which if you put it a little on the table, which is slightly more towards the head end, then there may be a difficulty in doing resection at 10 and 12 o'clock. So always the buttocks should slightly come out of the table slightly, so that you have a very good rotation of the resector scope. Any comments on the positioning and shaving? Shaving, they said that it's not important to do a shaving in TURP and probably not done. So any comments on these two? Yeah.
Very good point. I think Dr. Mukesh showed in his presentation the illustration on position, and that is absolutely the way to go. I would also just add one more point, that you can actually have the foot end down, the patient's, the belly and the pelvis down, or the other way down. In transcatheter resection, when you want your irrigation fluid to flow back into the bladder, then you can have head down and pelvis up. Or if you're operating close to verumontanum and posterior lobe, you can have pelvis down and head and up. So you can judiciously change this tilting also.
Yeah.
The point that you made about buttocks on the edge of the table is very pertinent. Sometimes your putting instrument into the urethra is also difficult if you don't have the patient to the edge of the table. That point is very good. But over and above, whether you want head and up or you want head and down, this also should be judiciously utilized in transurethral section.
Right. So what about one question that I was just wondering about the CT MRI you said, can we do the same thing with transrectal ultrasound? So if the transrectal ultrasound also give a very good picture of the prostate along with the urethra or catheter in situ. So if we have because we have also in our department only transrectal ultrasound.
Okay.
What do you think? Yes.
You can do that, but all said and done, this is a very subjective investigation. And actually, I have TRUS in my own clinic. And my technical assistant does it, and I see in my own chamber the picture TRUS. So that is so much close to me. But even after that, I will say that the TRUS resolution of image and TRUS, to me, it has not given that kind of visual perception which an MRI or CT would give. And then, if I had been doing TRUS all the time, where would you create a bank of images like the one I created for you?
Yeah, that is right.
So TRUS is so difficult. If I put a TRUS picture on the screen, nobody will be able to understand what you are showing. So TRUS
images are very clear. Yeah,
images on CT are very clear.
Very clear.
So MRI is even much better. So, and then you can, once you have a picture, you can ask them to give you a video of the prostate these days.
Yeah,
they give me a video of the screen, and it's so easy for me to understand it.
Right.
Yes, Dr. Shivam. So
maybe
yes, Dr. Anil.
Regarding the position, whenever my assistant asks me, sir, what is the position of the patient? I always say cystoscopy position. I never say lithotomy position. So this 45-degree angle to the thighs, this is a cystoscopy position, and this is written in the books. Somehow, for the reasons that Davies Lloyd stirrups are out from the market. Initially, there used to be Davies Lloyd stirrups. So that is the best way of doing urological endoscopic surgery, using these Lloyd Davies stirrups.
Lloyd Davies stirrups, right. So many of us do not have these Lloyd Davies. And I think you should also have a comfortable stool. The surgeon should have a comfortable stool where you can go up, down also and move forward and backward also. So that also would be very helpful for the surgeon.
Very helpful.
Yeah, right. So secondly, now we are trying to pass the cystoscope or pass the resectoscope. So how many of us, because we are now almost routinely doing a Otis urethrotomy. So what we have seen in our experience is because before that we used to put the dilator. So after Otis urethrotomy, this is our experience that the stricture formation is definitely less. So what is your experience, both of you, about the Otis and dilator before passing the resectoscope? This was again a question in the chat box also. Yes.
Actually, Dr. Shivam, I have practically never used Otis urethrotomy, although I had it in my department from the very beginning. But I relied more on what Dr. Jain said, lubricating urethra very well. And if you pre-dilate the urethra with Clatton-Bugis once, then your movement of the sheath in the urethra is easy. And if you are doing good transurethral resection and your duration of procedure is also not too long, right? So I think you can still manage to have very low stricture rate. And everybody has a stricture share. I also have a stricture share, but I don't think that it is so much for me to change my perception.
Okay.
Only thing is, late Dr. Harish Chandra used to show me cut with Otis urethrotomy, and then looking at with the urethroscopy, it used to give me a very terrifying sight that you cut the urethra so much here and there, it's oozing a little bit. And so I thought, why make a raw area in urethra and put a catheter? Now when you put a catheter and there's a raw area in the urethra, it will heal by 4 or 5 days time. That much time it will take to epithelize. and you can have a pericatheteric bacterial colonization, and this urethral site can get colonized sometimes. So it may be your choice, perfectly fine, and I have nothing against Otis. Maybe I am biased. I am biased about the bougie, and I've never used Otis uretrodome, so that's maybe the reason.
Yeah.
Maybe you can tell me more about it.
I would request the technical team to please reduce the disturbance, please. The technical team. Yes. So what I was saying.
You tell us more advantages of using what. Maybe I convert myself. I change myself.
The technical team, please reduce the disturbance. Yes. What I was saying that the beauty of the Otis uretrodome is that it doesn't make an incision or cut elastic urethra, normal urethra. It only cuts the fibrotic part. So usually what in our experience, we haven't found any this kind of raw area and which bleeds and oozes when we pass the cystoscope after doing a Otis uretrodome. So I think, but it could be a matter of opinion for different surgeons. Anyway, so another question was for the beginners, which resectoscope should be taken, either a single stem or a double stem? Does it make a difference?
I don't think so.
No. You don't.
No,
so
I don't think that makes any difference.
Yes. So double stem, single stem probably doesn't make a difference. But when when I first took my resectoscope, both the things were available. The rotating sheath were available, and it was a without rotating sheath. It was a continuous irrigation resectoscope sheath was available. What I found that in the continuous irrigation resectoscope, you can even remove the outer sheath and do the resection with the inner sheath, which was 24 French. And with the outer sheath, it becomes 26 French. So in Indian patients, if sometimes when the urethra is narrow, which you often find, then you can do with only the inner sheath, the whole resection. So it helps to pass the resectoscope. Whereas in a rotating type of resectoscope, you cannot do that. So I remember I just bought that thing. It was almost 25, 30 years back. I bought it only for that reason, that kind of resectoscope and not the rotating one. Any comment on that?
Yes, because Indian patients have, usually they have narrow urethra. And that is why there is a selective role of Otis uretrodome in some patients. In my practice, I don't find the use of Otis uretrodome maybe less than 5% time is used of, but it is a good instrument and it is required in some patients. And before doing Otis urethrotomy, the resistance on the resectoscope versus after doing urethrotomy, you can realize it. But that should be done only, not routinely. It should be done only in those selective patients where the urethra is really narrow and your resectoscope is tight.
Right.
I have one.
Yes, Dr. Yes.
Am I audible? Yeah.
Yes.
I only remember one instance of this was a very obese justice of Lucknow, and who had to be operated by transurethral resection, and Dr. Harish Chandra was operator. And this man, when put on the anesthesia table, had a very, very small penis. It is buried inside the scrotum. His urethra is very small. Cystoscope, 19 French, it goes in, but then he realized it's a very small penis to grab, hold, and very narrow. And his prostate was 70 cc. So he had very tough, and he had short suspensory ligament. Everything you name odd was there, and the patient was very VIP. So that time he did a perineal ureterostomy on the patient.
Yeah, exactly.
And through perineal ureterostomy, he did transurethral resection.
Yeah.
Only time I saw managing a narrow urethra, and you don't have Otis uretrodome, and you don't have to dilate, and very VIP, and you have a tough job ahead, large prostate to handle. So, and this perineal ureterostomy was done very nicely. He operated, closed it, stitched it, put a catheter. Everything went fine. Nothing happened. But if you don't do this and struggle with the tight urethra by dilatation, Otis, see, it is not your introduction of sheath into the urethra which creates stricture. It is the duration for which you retain the sheath and urethra which creates the stricture. If urethra is tight, relatively tight, somehow you manage to go in. But then you retain the sheath for 40 minutes, 45 minutes. So that point is also important. So there he said, I will not keep the sheath through urethra, I'll put the sheath through the perineal ureterostomy and do the job. And everything was fine. So don't hesitate in
doing a pen. Yeah, exactly. This is written in the literature also. To if you have problems, do a perineal ureterostomy, and this can help in even patients who have a long kind of prostate and and your resectoscope doesn't reach till the bladder neck. So that it can help in those patients also, and definitely patients with stricture urethra and small penis. Also, as you said, definitely this can be a very helpful procedure. Thank you very much. And then we go ahead with once you have passed the resectoscope, which kind of approach you think would be the best? Like I do it by the Nesbitt's kind of. I do it first at the roof and then go down, and then first definitely if there is a median lobe, you will resect the median lobe, go up, and then resect the lateral lobes. So any tip on that, or it is a surgeon's preference?
It is definitely a surgeon's preference, but what I feel from all theoretical and practical points, what I feel is that there is no doubt that median lobe first is first. After that, I go with an approach that for some reason, if I have to stop in between and I have to leave the operation in between, then the patient should void. So this is my approach and this is my aim also. So what I do is I resect the 5 o'clock to 7 o'clock groove first, define the false capsule, and then I go all around. I do not touch each and every surface of the prostate at the same time, because that creates a lot of bleeding. So I do median lobe first, and then I do the groove first in the base, and then I keep on going according to the patient's condition. In this situation, if I have to stop somewhere in between for some reason or the other, which will happen in your lifetime at least 2-3 times. So this is what my approach is.
Yeah. Any comment by Dr. Dalila?
Yeah, that's fine. Perfectly fine. I've already shown you my choices. Exactly. I've shown the video. Yes, I've shown the video. But my purpose of doing lateral groove technique first is because it is from where the main arteries enter the prostate. So if you tackle them first, the adenoma which falls into the prostatic urethra is devascularized adenoma now, and your vision is clear, your blood loss is lesser.
Exactly. So wonderful. The median lobe resection that you showed first on the 2 lateral sides, make 2 grooves at 5 and 7 o'clock, cauterize the vessels, and then start the median lobe. That is also wonderful. So what I also feel that first you should do the floor. If there is median lobe, yes. Even if there is no median lobe, do the floor first, so that you cauterize those 5 and 7 o'clock Badenoch vessels, and then you go up at 11 and 1, so that you again cauterize those flocks arteries, so that the resection is almost bloodless at times. So I prefer going top above and then coming back to the lateral lobes on the floor. So that is the point of technique that I would prefer. So there was one question about the commonest perforation that occurs at the trigone, at the subtrigonal tunneling that many a times the beginners and often many times the experts also would make. So any tip or any trick to avoid this trigonal tunneling? Dr. Anil and Dr. Divakar, any tip? Though the presenter has showed that yes, you should go deep into the median lobe and not just cut straight, so that you resect the bladder neck. So that is one of the tips. Any other tip if you want to say?
Actually, see, the subtrigonal perforation can happen by various ways. One way is that when you are resecting the median lobe and you're resecting at the floor, and you cut a little too much and you go subtrigonal. This kind of injury by experience becomes much lesser and lesser because you are doing it under vision. What happens is that when you are using an ileocoactor and you have taken the sheath in and out, your sheath comes in the prostatic fossa, and you're using ileocoactor and you introduce the sheath back into the bladder. This is a blind maneuver. And it is at this time you enter with the sheath into the subtrigonal area and then bleed. bleeding happens. I have seen this kind of thing being created by my residents more often. And this start bleeding, you have to put catheter, put traction, and then it makes really mess of it. So for the first variety, the subtrigonal tunneling, only thing is if you're a little careful with the vision and TURP, your vision is good, then you will not make this kind of stupid thing to cut the trigon too much, if you're aware about it.
Exactly.
And second thing is not, you learn only by experience, you've done it 2-3 times wrong. Even the catheter can go in the subtrigonal space.
Yes.
If you resected a big prostate and you created a big fossa, your catheter will go in prostatic urethra, it will coil in the prostatic urethra. If you push more, it will go in the subtrigonal space. That is the reason I put catheter on an introducer.
Right.
Not just like that.
Yes, I agree with you. All the three varieties can happen, and with experience, you can avoid all these things. In fact, if I see that the prostatic fossa is, the bladder neck is much anterior and having a curvature like this at the end of the resection, I place a guide wire and put the catheter on the guide wire, so that the third variety of tunneling doesn't happen. The second variety of tunneling is much more common than the first variety, because the first variety usually goes on, down and down with the experience. So this is what you should. And if you have done it, don't worry. Go inside that, do a good hemostasis, put the catheter on a guide wire, everything will come down and everything will heal.
Right. So I think the most important point here probably is, even if you have made a subtrigonal tunneling or resected the bladder neck, be very careful to pass the resectoscope sheath, because many times the beginners would pass this resectoscope under the tunnel, in the tunnel, and it will cause more space and you will just go into almost like a black space. So definitely it is very important. So again, there are a few points about all right. Anything you would like to say about the bleeding, oozing around the prostate? Like sometimes you find that there is oozing, particularly the venous oozing, which happens afterwards. So would you like to do a rollerball on the whole surface of the prostate, which you have removed, or just the traction would help in most of these patients?
See, my experience is that the venous bleeding cannot be stopped by the roller ball or the ball electrode. It cannot be. So you have to recognize first whether it is arterial bleeding, particularly small artery versus venous. The bigger artery is very, very obvious. So once you have done a gentle coagulation and try to stop it, and if you see that by repeatedly doing it is not getting stopped, and the characteristics of the venous bleeding, which we all know, if we have recognized that it is venous bleeding, then it is better to leave it, do evacuation of the chips, do a reasonable hemostasis, and put the catheter as soon as possible and inflate the balloon, and you can put a little bit of traction. So this is the only way of controlling venous bleeding. There is no other way of controlling venous, in my experience.
Dr. Dalila, any point?
Yeah. What Dr. Jain is saying, absolutely fine. You differentiate three kinds of bleeding: arterial, venous, and sinus. So arterial venous is fine. I want to just make a word about sinus bleeding. The sinus means you have perforated the capsule and bleeding has started. Now usually these sinus perforations happen in the end of the procedure, terminal part of the procedure, when you are trying to over clear the prostate and do a good job, and somebody is standing at your back and you want to show something better kind of thing. So there where you have more perforations which happen. But sometimes, particularly like subtrigonal, God unwilling, if that happens in the beginning, you just done 10% of TUR and you create a big sinus perforation and it is bleeding also. Now you are in a problem that if you continue the transurethral resection, patient will absorb the fluid. Even in bipolar TURP, patient will absorb the saline. He will not get dilutional hyponatremia, but he might get circulatory overload. So how do you manage this bleeding sinus which happens to you in the beginning of transurethral resection, and you have reputation at stake? To complete the TURP, patient may be very VIP. So in that situation, I have done this twice. I have removed the receptoscope sheath, I put in a catheter, applied traction, and put a finger in the rectum, and two finger in the rectum and balloon traction, and with finger in there, and put compression.
And wait.
When I put compression, wait for 5 minutes.
Yes.
And then remove the catheter.
Yes.
And put the sheath back in. Now you find the sinus bleeding has stopped. A clot has formed in the sinus. Now when you continue with transcatheter resection, your fluid will not be absorbed through this clot. The clot becomes a barrier between your irrigation fluid and the bed of the sinus. And you can continue your operation. So this trick works when you open the sinus in the beginning of prostate and big sinus. Sometimes you open a sinus, they don't bleed. If they don't bleed, that's fine. You can go on. There are small sinus openings. You can even cauterize with bipolar electrode. The smaller sinus, nothing happens. What I'm talking about is the big sinus that you open subtrigonally and it's bleeding and your vision is getting lost. For that kind of thing.
Very good point. A very good point for the beginners. And if there is a sinus bleeding, how to proceed. And if this helps, definitely it would help them to proceed with that resection of the prostate. And one question was about the bipolar and monopolar. What is your preference, bipolar or monopolar?
For me, it's only bipolar now for last 7 years. My monopolar system is somehow not being used.
Okay. And Dr. Anil?
I do both. I do both according to the availability of the instrument at that particular time. I have both, but I do both. It's not necessary because we are a team. So sometimes monopolar, sometimes bipolar. We do both.
Okay. So no preference, right?
No. If given choice, I will go for bipolar.
Okay. Okay. So right. Yeah.
And particularly in
Dr. Divakar, you are muted. Dr. Divakar, you are muted. Yes.
I will do bipolar, particularly in elderly patients where there are comorbidities. I will always do bipolar in those patients.
I must also share that bipolar becomes more expensive for the patient because saline that you use, every 3-liter bottle has a cost. But in monopolar, maybe if you're using glycine, that also will add to cost. But anyway, for last 7 years I've done bipolar, and I'm a great fan of bipolar technology.
All right.
See, one thing it also done is, you remember that we used to have rigors post-operatively. After the TURP, the monopolar TURP thing, for some reason, post-operative rigor in my practice was very high. And I always used to wonder why this is happening, why rigors happen, and rigor in the room when attendants are sitting around, and then used to become quite a bit of scene. But ever since I'm on bipolar technology, for some unknown reason, this is completely gone. Now there's zero incidence of rigors in the post-operative period. And so that's a big, rigors would lead to high blood pressure, reactionary hematuria, and scare in the mind of people. So many things happen with post-operative rigors. For the same reason, I keep all my patients in my post-operative ICU for 3 hours. Don't let them go to the room till they are fit, fine, settled, everything fine. They have a cup of tea in the post-operative room, and then they go to the room.
Yes, Dr. Dalila. I also follow the same practice. For 3 hours or 4 hours post-TURP, I always keep all patients in my post-operative ICU. And
you give a cup of tea also?
Yes.
To the patient?
Yes.
To the patient immediately after surgery?
3 hours, within 3 hours or 4 hours. Before shifting him.
Okay, that's good.
This is another thing my anesthetist added.
Yeah.
He said, if you give the Indian subject a cup of tea, it is a sign that he is all right. His anxiety level goes down drastically. He has full confidence on the operation, and he is all gaga. Yes. And believe me, please do this with Indian patients in post-operative room.
Okay.
After 2 hours, because spinal is given with thin needle. There's no problem of making them sit now. After spinal, there's no spinal headache. Yes. Right? And you can make them sit after 2 hours. Remove the traction if you have applied. Watch in the post-operative room itself what is happening, and then give a patient a cup of tea. He's so happy when he goes to post-operative room. मेरा तो ऑपरेशन ही नहीं हुआ, जादू हो गया, डॉक्टर ने पता नहीं क्या किया, मुझे कोई प्रॉब्लम ही नहीं हुई, चाय और पीने को मिल गई अच्छी सी. So that's what it is.
And the
That's great.
patient satisfaction is the ultimate thing.
Yeah, that is great. Exactly. So only theoretically, what we also prefer, we have both monopolar, bipolar, but we are definitely bipolar seems to be good. The resection is better, and the tissue cut is also better. Everything, but only theoretical risk. They say that because the current passes through the loop only, through the resectoscope only, there is a heating of the resectoscope which may damage the urethra and may increase the risk of urethral stricture formation. But we have not seen any comment on that.
There have been enough randomized studies on this, whether bipolar TURP has more urethral stricture, and this was initially a paper came which said leakage of current through the sheath and from the sheath to the urethral wall and at penoscrotal junction you have stricture. But after that paper, whatever literature came has said this thing out, that if you do not have a high risk individual for developing a stricture, high risk is one who has had a catheter for a long time preoperatively, who had UTI preoperatively, who was diabetic preoperatively, had a small narrow urethra, right? All those factors which give rise to stricture. If you have them, then he is a high risk case. Otherwise, if that is not the scenario, stricture does not happen. And also with bipolar TURP, you see when you coagulate, you create a white coagulation. There is no charring. In monopolar TURP, you create a black zones. And this necrotic tissue will automatically undergo a process of necrosis and sloughing and falling out, and this will create an ongoing inflammation in the prostatic fossa. So prostatic fossa is decidedly more inflamed after a monopolar TURP than after the bipolar TURP. And if you have an inflamed fossa postoperatively, patient will have dysuria ongoing, and the dysuria is at the end of the stream. The stream comes in the end, बहुत दर्द होता है, पेट में दर्द है, urethra में दर्द है. This is because of inflamed prostatic fossa. This is much lesser if you do a bipolar transurethral resection. So it is for this reason, two reasons: less rigors and less dysuria. Postoperatively, I shifted to a completely bipolar methodology.
Yes, my
exactly. I think yes. Yeah.
But rigors I have not noted. I didn't study in so much detail, but postoperative dysuria is much less in bipolar.
Okay. I think that is also one of the reasons why some people would try to coagulate by roller ball after doing a TURP. They are trying to heat up those tissues, prostatic capsule, and cause more of damage. And postoperatively, these patients have more irritative symptoms when you do a lot of coagulation afterwards. So probably coagulation is not required if there's if you have taken care of the arterial bleed and significant bleeding that is happening. So I think we have crossed the limit of our time. We can go for hours on this subject probably. So if our moderator, Dr. Yadav, if he's there, we will have his last comments. Dr. Yadav, are you here?
We have.
Yes.
Can we have some comments on Nachiket? I saw him.
Yes, exactly. I was asking Dr. Nachiket. Yeah. Nachiket, you are here? Nachiket, please come in.
Sir, yes, I am here, sir. We had a wonderful...
Your last comments and vote of thanks.
Yes. I think that the residents, they have benefited greatly with the wisdom which has been given by Dalila sir and Jain sir. And especially even I learned many things about, the nitty-gritties of resection and the complication. The only thing that I have to add about, we were discussing in the last, the stricture rates. And I think that this had also been studied extensively post-TUR strictures by Professor Sanjay Kulkarni. And I think that one term that he has coined after bipolar resection, basically he said that there is a cheese grater effect. The outer sheath has got, number of small holes, and there has been change inside the manufacture of these small holes. Previously, these holes used to be absolutely punched out. But now the thinness of the sheath, the diameter of the sheath and the thickness of the sheath from which the outer sheath has been made, that is also decreased. And he has found that it is just like, when we are moving the instrument forward and backward and forward and backward, that creates a lot of congestion, and it causes a lot of pressure upon the prostatic, on the membranous, bulbomembranous junction. So he says that according to him, if the urethra is tight in in Indian patients, we find that the urethral size and the volume is lesser than our counterparts inside Caucasians and also inside the US and Europe. And so that is why, on account of this cheese grater effect, strictures are more inside the bipolar or inside our patients compared to vis-a-vis patients who are abroad. We have multiple studies coming from abroad that the instance of strictures is the same, irrespective of whether bipolar is used or monopolar is used. And it makes sense. This is because abroad they have all varieties of, sizes of resectoscopes based upon the size of the urethra. But over here, we only purchase one size, and that is the standard 24.5 French. And we use it also for all our patients. We do not, basically change our size of resectoscope. This is because it doesn't make sense to buy the 28 French also, the 26 French also, the 24 French also. So on account of that, I think that we have more instance of strictures. That seems to make sense, that cheese grater effect. And that is the only comment that I make. And today we were flooded with knowledge, and we thank both sirs, Dalila sir and Anil Jain sir. It was a wonderful experience, and even for consultants, we learned so many things today. And thank you for coming for our teaching session, and be safe. And we really had a great time, sir.
Thank you. Thank you very much.
Thank you.
Thank you. Thank you. Thank you again, Dr. Dalila, Dr. Anil. And
thank you.
All of those who have joined us. I can see a lot of people besides our department have also joined. Thank you for viewing. And you can give your feedback to us so that we can, in our coming time, we can even improve upon what we are doing now. Thank you very much. Thank you. And have a good day. Thank you.
One comment from my side, Shivam.
Yes, please.
Your this SMS urology class is becoming much more popular than many seminars and webinars.
Thank you, sir. Thank you very much. Thanks a lot. Thanks a lot. Thank you.
Okay.
Thank you.
Okay.
Thank you.
Bye-bye.
Okay. Good day. Good day, sir.
Thank you. Thanks very much.
Thanks.